as we heard. There was a quick echo, so make sure that you're muted when you don't speak. If you listen carefully when Hakeem speaks, please add your questions in the chat. We're going to try to get to as many of them as possible. And if we can't get to all of them, we'll make sure that he gets them afterwards and we'll try to capture the answers in a follow-up email. And you can name yourself and ideally your organization so we can see who's all in the room. And if you have any challenges, Nikita is on the line and you can privately chat her for some support. A little bit of background. We are here, or maybe we can go to the next slide and just see who we're going to see today. I'm managing the welcome, then we will hear from Hakeem for the vast majority, and then there's going to be Q&A. But a little bit of background. We were meeting with Health AI Partnership over many weeks and started to feel that we need to do more to make sure that the safety net has a way to actively, on an ongoing basis, learn from each other. So the AI infrastructure in the country has really taken off in large academic centers and the big health systems. The train has left the station a long time ago, and there's constant learning, and there's dramatic increase in investments. And at the same time, we see that there's huge needs in the safety net. Some of the biggest needs can really benefit from AI solutions in the safety net. But there's started to be some adoptions. And we want to make sure that in this semi-unstructured
That
build a community of people that can hear from each other and learn real time about early adopters and champions, and for you to ask questions. We see this as seeding more work together with partners to bring resources and collaboration for AI adoption in the safety net. The last time on the inaugural session, we heard from Dr. Tarabishi, who is Chief Medical Informatics Officer at Metro Health. And the main takeaway I had from that presentation was how important it is to monitor when you deploy an AI solution. The one story that I took away from him was how they used an AI solution in the EHR to reduce no-show. And it did. But then they looked at what are other unintended consequences, and they saw that it was a significant increase in double booking for African American patients. And then they had to question themselves, what problems are we solving for? And if this is to address inequities, we have to do something differently. So they went back and they reworked the algorithm and then went from increasing the double bookings for African Americans, managed to reduce the no-show rates for African Americans. So my main takeaway was it's not enough to just vet the solution and manage the workflow integration to get it started, but then really pay attention to what are the unintended consequences and how can we make sure that it really is in service of addressing inequities. If you were not in that session, very rich, we will send the link to that in the follow-up email. But here today, we are going to have the real pleasure to hear from Hakeem Adiani, who is the Chief Clinical Officer at Sacramento Native American Health Center. And I'm not going to stand between you all and hearing from him. He has a great presentation and experiences to share with you. Once again, any questions, please put them in the chat. And off we go. I'm going to stop share, and Hakeem, you can start at your end.
I'll make sure that shows up correctly. Can you see my presentation?
It's perfect,
Yay!
and we can hear you very well. So
All
thank
right,
you.
perfect. All right, so thanks again for having me for the second meeting. I'm really excited to present. A little nervous at the same time, but hopefully the nerves will go away. Um, Share the agenda, which is maybe a little ambitious, but I'll give you a little bit of background about who I am, how I got to this position, what kinds of stuff got me here, trying to be a tech nerd, a little bit about my clinic and the patient demographics. I always try to sneak in some information about quality improvement. So we'll hear a little bit about that. And I'll talk about a couple solutions that we implemented in our health center and some of the things, key takeaways that we had, some obstacles we're still trying to navigate, and some of the next steps. I have no disclosures. I don't get paid by any of these vendors. I'm not currently a consultant, so no conflicts of interest there. Just a little bit about who I am and how I got here. All of these are FQHCs. All these are part of the safety net. Started back in residency at UCSF at San Francisco General Hospital, where I did some. I was always one of those people that I wanted to work smarter, not harder. So I was all about trying to use tech in any way possible to make our lives easier. I was part of the transition from paper charts to EHR, which wasn't that long ago. I had similar experiences at La Clinica, a large FQHC in the Bay Area, where I served as the regional medical director. And I was the first person to go up on our EHR there. So I felt all the pains. And I am a glutton for punishment. And I've served in similar capacities at Peachtree Health and at SNAC. We don't have a CMIO, but since I'm really into tech, I serve in that capacity as well. In terms of the clinic that I currently work for, SNAC, the name can throw people off, Sacramento Native American Health Center. We do serve a large Native population, American Indian, Alaskan Native, but they're not the majority of our patients. They probably make up around a quarter of our patients and a third of our patient encounters. We provide care to those who have Medi-Cal, which is California's version of Medicaid. More than 80% of our patients fall into that category. Very few are private insurance, and we'll see what happens with self-pay. That may change with the current changes within the administration. We are a patient-centered health home. Our patients have a number of conditions, like many of us that are on the call. More than half of our patients have 3 or more chronic conditions, and many of them have dual diagnosis with mental health and/or substance use. With that said, one of the things that I really like to look at whenever we're trying to implement change within our health center is the Institute for Healthcare Improvements quintuple aim. You'll see the timeline here in terms of the triple aim looking initially at improving patient experience, better outcomes, and lower costs. As many of us know, healthcare is super expensive, and there's a lot of redundancy that plays into it without necessarily bringing about better outcomes, and a lot of our patients don't really have the greatest experience. They then moved to 2014 with the quintuple aim, where we took in the clinician well-being. But at this point, we're really looking at a care team model, the care team well-being, understanding that there's moral injury, there is compassion fatigue, burnout, whichever term you prefer, trying to ensure that we're addressing those things. And then more recently in 2021, recognizing that health equity is a key component, that we do need to really, as already mentioned, we have to vet, question, analyze whether we're having differential outcomes based on any number of factors, whether it's socioeconomic, racial, ethnicity, sexual orientation, and other. And hopefully when you look at all those things, you come out with better health outcomes and better stewardship of the funds associated with it. So when we were looking at specific opportunities to leverage technology, those are the things that I always pay attention to. If it's not really addressing any number of those things, it's not really beneficial for us. With that said, I will say that I'm not talking about ChatGPT. It's not that I'm against it at all. I use it probably every day for non-clinically relevant stuff, whether I'm working on policies and procedures or looking at some contracting stuff. It is something that I think still has a benefit, or similar things can have a benefit. But for this presentation, I'm really looking at AI specific for healthcare. So some of the things that we tend to pay attention to for the functions of AI in healthcare are just listed here. So clinical documentation and chart abstraction. I know that that's a key component of what I'm going to talk about. Another thing that is of interest, but of varying success, is AI-generated patient education, recognizing that our patients only remember about 30% of the stuff that we say during a visit. So what are the opportunities that we have to leverage our technology to provide them additional education? In theory, it's supposed to help improve the patient experience in terms of communication. And then depending on where you are, looking at clinical measure documentation, making sure you're getting credit for the things that you do during your visit, that depending on your health system or EHR, if it's free free text information versus in discrete data fields, whether you get credit for the work that you're doing. And then coding in terms of recognizing that as we move to alternative payment models and recognizing the level of complexity for our patient encounters, making sure that you also get credit for the work that you're doing and the complexity that you're having to address with your patient population. And then lastly, something that I added in terms of education for us as staff. So with that said, these are the two platforms that we had implemented at our health center. Again, not a plug for either one of them, but more so to let you know what we've been able to use, and I'll speak to the experiences that we had with both. I'm going to start with open evidence and move to the one related to EHR. So open evidence is AI powered platform, medical platform, similar to something like UpToDate. It's something that is sponsored by Mayo Clinic and the New England Journal of Medicine, and something that I recently learned about, I want to say within the last quarter of the year, from social media physician groups. And what it does is provide you an alternative to some of the things that we use now. I know previously in my training, I used Dynamed, Hippocrates. I currently use UpToDate, and I recognize that there are opportunities for some other stuff, and recognizing also that cost can be a challenge. This is a free alternative. So it's free to any US healthcare professional. You just have to place your NPI number inside to register. There's app on both iOS and Android, but there's also a web-based version. And one of the things I really like about it is that you can put in specific clinical vignettes. You can just write whatever you're thinking, try to synthesize it and bring about articles that address that and recommendations. And they provide hyperlinks to the reference articles, namely from the New England Journal of Medicine. And then you can provide feedback to see if it's actually providing you the information that you think is relevant and useful for the care of your patients. This is a screenshot of what it looks like on iOS. It is pretty easy to read. As you can see, the question is, which patients with pulmonary tuberculosis can be treated with a shorter treatment regimen and why? That's a question that many of us will come up with. And if you put it into some other platforms, it won't give you an answer, but this helps synthesize that information. So the interface is, I believe, user-friendly. The fact that it supports iOS and Android is important. I'm an Android user, and sometimes when it's only iOS, I want to scream inside. There's obviously using your native language, you don't have to figure out the right term to glean information. And again, it's another opportunity to try a different platform, especially if your health center or whatnot doesn't have something like UpToDate or doesn't fund it. Some of the considerations that I did have in using the platform were around how long is it going to stay free? That's one of the great things about it. It's a free platform for anyone, any healthcare professional, but free things don't always stay free. The lack of CME credit, I know for a number of folks who use UpToDate, they don't rely, but there's the added benefit of every time you do a search, you get a quarter or 0.5 CME credits that you can use towards your continuing education that's necessary to maintain your certification. And then in terms of resource support, as more and more people use it, one of the things that I've noticed is that it sometimes crashes. I had never had that experience previously, but that did happen more recently. So that's something to consider. The static evidence presentation, that's similar to what you would end up seeing on something like UpToDate, where it's only based on the information that's readily available at that time, and there can be a lag. But I will say that the lag is probably a lot shorter than with something like UpToDate. And again, I'm not against UpToDate. I still use it regularly. But if there's been a new article that's come out in the last week, open evidence is more likely to bring that information into the response than UpToDate is, because it's usually monitored at most quarterly, but sometimes annually. And then one thing that uh, is a consideration, and this is something that's also evident in other AI platforms, is the potential AI hallucination, meaning that it could potentially bring in information that's just not real. I haven't experienced that, but that is always a consideration when using AI-powered platforms, that it's actually able to refer back to uh, true evidence or an article. And then the last thing that I think differentiates it currently from something like UpToDate is that you don't have patient-facing education. With UpToDate, if you were to look up certain conditions, you'll have the provider-facing information, but you may have a patient handout that you can give to your patients to provide them some information about the condition that you're working them up for or have diagnosed them with. So that's that platform. Again, it's something that I think provides value, and it's something that you're able to compare with what other resources you have available to you. I've done some side-to-side comparisons, side-by-side comparisons, and I've really appreciated the response. I know while I'm in my exam room, I have open evidence open, and sometimes patients will ask me a question that I don't quite know the answer in that moment. I'll plug it in, and then I'll look at the reference documents, and I'm able to at least provide them some information in real time, which I think has been beneficial for the patients and for my own edification. Now moving on to the EHR platform. Again, I've been a next-gen user since, oof, I'm going to date myself, 2013. So I've seen every iteration that they possibly have had. And next-gen ambient assist is just their version of an AI tool that can be used to help document our clinic visits. And part of the reason why we looked at this is we recognize that there's a lot of pajama time that happens within clinic. As I mentioned previously, more than 50% of our patients have more than at least 3 or more chronic conditions. So the reason for visits get really long, and you only have 15 to 30 minutes to see the patient. So we wanted to give our folks time back to be able to provide the care that they are capable of providing, and provide the time to the patient. So with that said, there were some considerations that we had around ensuring that there's safety with this platform. So things that we considered were understanding information ownership and the cybersecurity needs. So understanding whether the information is being stored somewhere, whether who has access to the information, and what is the security needs or recommendations? Is it behind several firewalls? Is it something that's going through a remote desktop through our own system? Is it living elsewhere in some data farm? Those are things that we needed to consider. We also looked at the interoperability with our EHR. So there are a number of different platforms that are out there that either integrate with your EHR or sit outside of it. And one of the considerations for us is we didn't want to create more work for our staff in terms of copying and pasting, or having to create new SFTP connections, or having to do a health information exchange. We wanted to make it as seamless of a transition as we could. One thing that we also considered, but are still trying to look into, is just the transparency of the AI decision making. Currently, this product isn't giving guidelines as to clinical treatment, but it is trying to synthesize what you've written in your chart note and providing you potential diagnoses. We wanted to make sure that we were limiting it to that and not trying to provide the treatment plan at this time. And with all products, you want to make sure that you're HIPAA compliant. There's a whole bunch of vendors out there that say that they can do stuff, but if they aren't able to meet those regulations, it's a no-go, and should be a no-go. And then we wanted to make sure that any information that was going in, we had an opportunity to, again, vet it, review it, edit it, change it, eliminate it if we felt as though it wasn't useful. And something that was already mentioned in terms of the bias detection and the AI models, that's something that we're looking at more so from the language standpoint, but in some other products that we're looking into, that's something that is going to be much more highlighted. So for next-gen ambient assist, these are some of the claims. Used artificial intelligence to listen and transcribe clinic visit conversations. It is an app, so it does require more than one device. So it requires uh, a cell phone or a tablet to be able to transcribe and listen to the conversation. It does convert whatever you're talking about into a SOAP note. So it is actually, that part of the note is pretty, but I'll speak a little bit more about how that looks in terms of regular SOAP notes. And it tries to generate the notes in a way that is clinically relevant, but you still have an opportunity to edit it. And currently, just for this product, it supports documentation in both English and Spanish. So these were some additional claims. And in all honesty, these were things that I did note for myself. I was able to walk out of most rooms with my clinical note completely done. I know historically I talk way too much with my patients, or that's what some of my ops folks would probably say, but this allowed me an opportunity to still have those conversations and not have to spend hours later trying to synthesize what we talked about over the day. As a result, I did feel as though I felt a lot more refreshed after my clinic visits. As a point of reference, I'm only in clinic several half days a week, but I'm seeing like 14 patients in a half day. So it's back to back to back. So I needed something that allowed me to get the work done, but not lose sight of the actual patient encounter. And it definitely freed me up to spend more time in the patient relationship. I spent a lot less time looking at a screen and more time just having the conversation and addressing patients' needs. And then one thing I also noted was I spent a lot more time verbally explaining the assessment and plan with patients in twofold, to ensure that it showed up inside my chart note, but also to allow for the patient to have a better understanding of what the next steps were. Some features that I didn't get a chance to really play into is the macros. So being able to say a phrase and having something automatically drop into your chart note. That wasn't a feature that we had initially. That's something that we're actually adding in the next week, but that's another consideration. So some of the observations I had during this, like I mentioned, less in-visit screen time. Let me get rid of that, which was helpful. One thing that I did note was I think I'm a great writer. How the chart notes come out is different from my regular writing style, so I had to get used to that. The HPIs were a little less descriptive than I'm used to putting into my chart note, and I still did have to use some additional time to look at the chart note to update information that I didn't think was quite right. In terms of mapping challenges, while the SOAP note that it generated looks good by itself, I'm not sure, for those that aren't familiar with NextGen, it is very much discrete data fields. And what we ran into the challenge of was that the SOAP did not go into those discrete data fields. It was a completely different template that didn't show up in our regular SOAP. You had to click a separate template to have it show up. And when you generated the note, the notes became kind of bloated because you still had to put in your regular assessments that showed up in a different area. But this SOAP note was put together in an area that was not located in the same place. Another thing that I found challenging was that given the fact that it can interpret, it can help write the assessment and plan, the fact that it didn't automatically generate some patient education or help with the patient plan, I thought that was a misstep for us. And then lastly, the language concordant visits. I'll speak a little bit more about that. So for us in California, again, Medi-Cal is California's version of Medicaid. These are the top languages that we tend to see throughout the state. And depending on where you are, you're required to have documentation in the top 5, 6 languages. And if you're lucky enough to have physicians that speak those languages, you want to make great use of their time. One of the challenges that we ran into is that if we have a Cantonese speaking physician who's speaking to a patient in Cantonese, they could not use the platform at all. because it had no way of interpreting the language. And even for me, who speaks Spanish with most of my Spanish speaking patients, there were still some things that were lost in translation when I was going back to look at the chart now. So that's an opportunity where, at least for this AI platform, we ran into some issues. I have talked to other AI platforms that claim to support up to 105 languages, but as we all know, dialects make a difference, regions make a difference. So getting direct interpretation of language can be challenging. So in that situation, we recognize that there is a built-in inequity for those that speak other languages because we could not use this platform in the same way. If they're using an interpreter, that's different. But in our setting, we allot more time for interpreter visits. So we recognize that it takes at least 40% more time to do an interpreter visit. So instead of a regular 15-minute visit, we do a 30-minute visit. So that impacts costs, impacts productivity, revenue, and things of that nature. So if you have the opportunity to have someone that speaks the same language, you want to be able to take advantage of that. And we weren't able to take advantage of that in this situation. The next slide is just a representation of the other languages throughout the country, other than English or Spanish, that are dominant. So again, there are a lot of languages, and none of these languages were supported in the platform, which presents a lot of challenges for us, and I'm sure would present challenges for a number of the folks that are on the call. So some considerations based on that language support. Like I mentioned, there are other programs that claim that they can support up to 105 languages. We're going to be pushing on NextGen to support more than what they're currently supporting, and making sure that they're, for lack of a better word, interpreter/translation services actually has a better way of capturing language, because we did find a couple of discrepancies when interpreting our Spanish language appointments. Other considerations that we still have to figure out is the informed consent. I know for myself, I was having to let patients know every time that I walked into the room, I'm using this tablet to help capture our visit so I can spend more time talking with you and less time looking at a screen. If you say that 14 times a day or 25 times a day, that can get kind of taxing. So figuring out whether we have an opt-in policy that's written out that patients get sent to them and is posted out throughout the clinic, or an opt-out policy, so that we're able to say that this is normal part of our practice. And if folks decide to opt out of it, they're given the opportunity to, but not necessarily having to talk about it literally every single encounter. In terms of technology supports, again, for open evidence, they supported iOS and Android. NextGen previously supported both platforms, but they decided that they no longer wanted to support Android. So that provided some challenges, since, like, for myself, I'm an Android user. So our organization had to provide a tablet or a phone for me to be able to actually use this software, which incurs costs. And we haven't decided that. And then the internet connectivity. I know in some of our health centers, there are certain dead spots. And when that happens, you lose connectivity to the platform. So you're doing your visit and you think everything's capturing, and then you see that there are no words that are captured in your visit. So that can be a little bit deflating. So making sure that you have those supports. And then another thing that came up in our conversations was around telehealth. While we still have the opportunity to do it, I'm lucky enough to have my own office, so I can be on a speaker, do a telehealth visit with the tablet or phone on the desk, and the speaker talking with the patient. But in many situations, your staff may be in pods or shared offices. Being able to do that just doesn't work. And our platform wasn't able to support doing the visit through the tablet or through the phone while gathering the information for that AI interpretation. And then the two other things that I kind of mentioned previously is whether we wanted a standalone platform or whether we wanted to continue with the EHR integration. Because right now we're actually exploring whether there are other HIPAA compliant platforms that allow us to use Android products so that we don't have to buy a whole bunch more uh, iPads, iPad minis, iPhones to allow for our staff to use it. Some additional things that we've also considered is just around some vendor requests, like I mentioned, the AI generated patient education, mapping to the areas that are consistent with how we've already been charting, looking at the clinical measures and trying to pull that information and let us know what things may still need to be addressed during this visit. And then from a data standpoint, looking at how much time we potentially are doing talking in the visit versus the patient talking in the visit from an analysis standpoint, and how much time it's needed we're spending in the visit in general, so that we can see how it compares to those who are not using the platform. And then reminders and AI voice agent and outreach workflows, which aren't part of this current platform, but we're actually vetting 3 different platforms that may be able to do that and provide us support for multiple languages. Recognizing time, I'm going to move a little faster, but some AI considerations for patient engagement were a couple things. So the automated outreach workflows, so reminders, education, and making sure that's in the preferred language. Again, this platform only supports 2 languages, but other platforms support up to 105 languages, which is great if they actually truly support those languages. Being able to use the agents for the scheduling follow-ups in the preferred language, making sure that the technology accessibility is of it, like recognizing that many of our patients don't have broadband or don't have regular phones, and making sure that they still have access to a lot of these resources in some form or fashion. And addressing the bias in terms of the predictive models for no-show versus increasing outreach. So for us, one of the things that I would want to do and make sure that our product does is, if the patient is more likely to no-show based on our model, that doesn't mean that we're more likely to overbook over their schedule, but we're more likely to reach out to see how we can close the gap and determine if there's an SDOH that might be impacting their ability to come in to see us. We want it to be used to enable or empower or engage our patients and not to exclude them. And then in terms of our elders, recognizing that not everyone's going to be tech savvy, not using this as the only platform or only way in which we engage with our patients. And if we're going to use this, finding ways and vetting it with our key stakeholders, which are our patients, to see if there are things that they need for it to be useful for them. When you're looking at it from an investment standpoint, you got to look at how much it's going to cost from just hardware standpoint and personnel standpoint. So for us, the platform requires a subscription that they made us sign for at least a year per provider that's using it. In our example, it was $400 per provider per month. So that money has to come from somewhere. The way in which we were able to present it is that's 1.5 patients per month in theory that you would have to see in addition. If you're able to document your complete chart in 15 minutes, you're more likely to be able to accommodate that 1 patient every other week. Additionally, by us being able to document in that real time, we're able to get our reimbursements faster. So that was another way that we were able to address that. And then infrastructure support. So making sure that your broadband is strong enough to support this additional usage, making sure that you have the hardware available to those that need it, and then figuring out what kind of maintenance you're going to need for the system. We went through lots of different iterations of equipment to see what was going to make the most sense. And logistically, where do you put this equipment when you're inside the room? Is there a stand for it? Do we have keyboards attached to them? Do we have separate speakers attached to make sure that things are being captured correctly? Those are some of the logistics that we had to take a look at. And then, do you have folks on staff that can support it, or do you have to look at third-party vendors to support the platform? For us, we have some on-site staff, but we have a large third-party vendor that we use for ongoing support, and they have been integral in our implementation of this. And then how do you train folks on it? And how do you offboard folks from it? Is it something that's required of everyone, or is it something that people get an opportunity to decide whether they want to use it or not? When we also think about it from a resource allocation standpoint, like I mentioned, I trained at ECSF, a large academic institution with far more, a lot of money in comparison to any FQHC that I've worked with elsewhere, where we didn't have those same resources. So really having to determine, how am I getting the latest and greatest iPad to complete list, or am I getting the iPad mini that's a couple generations older that still gets the job done? Um, am I going to be able to spend more time researching a lot of these predictive models, or am I having to use something that's more out of the box and recognizing that there's going to be limitations that we have to assess ourselves? Those are some considerations that we have to think about, recognizing that we're in the community health space versus some of our colleagues that have those additional resources and people hours and power to address these other things. In terms of some of the training components, like we mentioned, continued staff education as to the use of it, peer reviewing the AI generated content. One of the things I didn't mention is, prior to having all this, there was a concern that some folks were using stuff like ChatGPT to create their part of their chart note, and having some parameters around that, and recognizing that we still need to vet and make sure that this information is consistent with our standards of care, making sure that we're able to look at what would be generated and using this product versus what we normally would document, to see if it's comparable. In some situations, it was stronger. In other situations, we needed to add a little bit more context. And then recognizing that there's still some uncertainty, since it is supposed to be a predictive model and it's still interpreting what is being said, trying to understand whether that is good enough. And whether you're good to go, or whether you still really need to spend a lot more time using your human expertise. That this is never, let me rephrase that. At this point, it's not replacing your clinical judgment as a clinician physician, but there are going to be more models that are going to be incorporating those things, but you still have to read it to make sure it makes sense. We talked a little bit about informed consent. So some things that we are considering, again, making sure that's completely clear to patients as to when we're using it and what situations. Currently, that's really just for our documentation, but like I had mentioned, we're looking at helping it with our scheduling, with our patient outreach. I know all of us have had experiences with automated systems that have been better and worse. So making sure that patients understand that there's still an opportunity to talk to a real person behind this AI work, but giving them that opportunity, and making sure that in those situations, some patients may opt out of the automated scheduling and outreach, and allowing that to be the case because they still want to be our patients, and making sure that we're putting it in plain language so that they understand what's going on. Talked a little bit about this previously, but overcoming the barriers. So the cost constraints, we talked about that. One of the things that we do within our organization, we do a ton of SBARs, so the situation, background, actions, and recommendations, to determine whether we're able to move forward with things, and being able to come up with rough estimates for ROI calculations. One of the biggest things that I use is, it takes 9 to 12 months to replace a provider if they were to leave. This costs $400 a month. If this is going to make their life easier, I think it's better than losing them. And I haven't lost an argument with that one yet. So I think that that's something to consider. If your staff is running into issues around just feeling tired, and this is not easy work that we do, and there's more and more things that we're being required to do in less and less time. These are small nuggets that can be put into place to help, making sure that they're put into place to help. Another thing that's important when you're running into starting something like this is making sure that you have staff champions, and that you have key performance indicators for adoption. In my situation, I tend to be the guinea pig for everything. I'm not going to ask people to do things that I'm unwilling to do myself, but you're not always going to have that person. So being able to identify people that are going to be the early adopters, are okay with running into every issue under the sun and providing that feedback to make sure that the product's better for people that are going to use it afterwards. The data privacy, again, we were lucky in the sense that it's already integrated into our EHR platform, but if you're going to be looking at something that's outside of that, making sure that they have those policies, procedures, those regulations as part of the work that they're doing. And then there was a question about other departments. As the chief clinical officer at my organization, I also help oversee the behavioral health and dental departments. And we've looked at AI interpretation in both of those departments and recognizing that all platforms don't work for all clinical settings. So being able to vet and make sure that they're actually useful in that. Currently, our platform doesn't support dental, which is unfortunate. But with an upgrade, we're going to be able to support behavioral health, and our behavioral health director has definitely been putting in a plug. So being able to use it in those settings is going to be important. But again, you have to make sure that your platform truly is able to deliver on what they say. And if they aren't, are you able to bring in other platforms to provide that resource to the departments that need it? In terms of key success, I always put this slide in as well, the second half. So 10 building blocks of high performing primary care. It came from the Centers of Excellence for Primary Care out of UCSF. I'm just going to leave that part there. But again, things that I think really are important. You need to have strong leadership buy-in. I happen to sit on our executive team, so it's easy for me to push these things forward. But it's important to have a clinician that's really into this stuff, that's willing to go to bat and try it all out. You need to have the infrastructure in terms of ISO, the software, but also the hardware support to make sure that you can actually get this done. And it's going to come down to dollars and cents, making sure that the finance team understands the benefits. It was actually easy for us in terms of having a conversation with the CFO, because the big thing was, if we're able to bill out encounters faster, we're able to collect more of our money sooner and able to invest it into the organization or into other things. So it was a no-brainer for him. Other things that I think are really important, making sure that you don't try to bite off too much at one time. For us, we have a total of 15 or 20 people that are on it currently, but there were 6 of us that started. 3 people dropped off very quickly because they did not like the product. And then we brought on additional people. We made sure that it was a trial. We weren't locked into a year subscription. We were able to negotiate to have a 3-month trial of the product to make sure that it was worthwhile. And each provider was given that opportunity, which I think really helped, because we realized some people, they love the way that they write their notes and their notes are fine. And other people, we are guiding them to use this product because we think that it's going to be better for them in the long run. We also made sure that we had forums. So we have a Teams chat for anyone that's part of the project to make sure that they can bring up any questions that are coming up, or if they're running into issues, to see if other people are running into it as well. I think that was really important for us, because we're like, hey, I'm running into this note just dropping off, and like, hey, I'm running into it as well. And then we were able to figure out it was a matter of a location being a dead spot. We needed to update the internet in that space and provide a boost or another router. And then we have scheduled check-ins with the vendor to make sure that we're giving them the same feedback. And then lastly, this is something that generally is very challenging for FQHCs, recognizing that you're the client and the vendor needs to provide you the resource. So being able to push back on them and say, these are the things that we need out of the product, and recognizing that there are other vendors out there that can potentially deliver on those things. When we look at it from the building blocks of high-performing primary care, obviously the engaged leadership, data-driven improvement, looking at what's happening in terms of who's using it, what percentage of the encounters they're using it for, which kinds of encounters they're using it for. Are we running into issues where it's not being used in Spanish-speaking encounters, other things of that nature. From a population health standpoint, we're still trying to see what that looks like. That platform that we're currently using can't meet that need, but looking at platforms that can engage in the population health and the patient registration in terms of the AI voice agent, that's something that we're considering. And then being able to improve our continuity of care because we're not having to book patients with other providers because they're running late. So I think the next slide is probably my last one, but some of the lessons learned. The AI assisted documentation did really decrease our workload. Like I feel confident saying that I walked out of most of my rooms with the majority of my note done, and I only had to touch up a couple of things. It did provide coding suggestions, which I think can be helpful, and it also was able to pull in a previous coding. I did help me improve my communication with my patients because I was saying the assessment and plan at the end of each visit. So it was capturing the chart note, but more importantly, I was providing that information to the patient. Examples of like, okay, for high blood pressure, your numbers have been great. Let's continue with this medication. We're going to follow up in about a month to make sure that you're not having any other challenges with medications. That would show up in my assessment and plan, but the patient also was receiving that information in real time. And I did that for every assessment and plan. And I think the patients have really appreciated that. Again, the goal will be for that patient plan to actually show up for a patient to walk out of the room without me having to generate it. The language concordance is going to be a challenge that we still look at. The mapping is a challenge that we're still looking at. We haven't run into nearly as much resistance as I thought we were going to run into, but when we onboard a new provider, is this something that they're going to be exposed to initially? And do they get a choice in that matter? Do we give them a chance to show us what their chart notes look like prior to this, or is this something that is going to be the standard of care? Things that we're having to consider again are around patient engagement, registration. One thing that I didn't speak on is just patient feedback in terms of the experience. We do CAP surveys. So being able to compare and contrast in terms of prior to initiating this, how did patients feel in terms of their communication with their provider, timeliness of getting referrals or imaging or other stuff? Because the other thing is, if your chart note's not done, you can't process a referral. You can't get certain imaging done. So that's something that we also want to take a look at, and whether patients feel as though their provider is engaging more with them during the visit. I know I was definitely guilty of this where the patient's right here, but the screen is right in front of me, and I'm spending way too much time looking at the screen, documenting, typing out to make sure that I'm not missing something when the patient is trying to get my attention, my visual attention. So I think that's probably it. I talked way too long, but I think we might have a couple minutes for questions. And I think I dropped the presentation in the chat. My email's on there. So if you have other questions, feel free to reach out to me. Like I'm an open book with stuff, and I like talking about this stuff. But thank you.
Thank you so much, Dr. Adenei. Hi, everyone. I'm Jessica with the Center for Care Innovations. I'm just going to help moderate our Q&A, and we'll just be in a full group here, try and get some more voices in the room if possible. Varun, you had a question around ambient scribes and kind of talking about are there instances where maybe you would have want to capture something in the notes, but maybe the algorithm didn't make that decision. And any instances you've seen of evidence where things you might have included in the notes didn't show up there?
Great question. So for me, it tended to be more social considerations that didn't show up in the note. There wasn't a specific theme, but that's one of the things I want to try to research a little bit more in terms of just anecdotally, what are the things that I'm having to add into my HPI and potentially what I'm having to add into my assessment plan. The assessment plan generally, because in essence, am saying it out loud, makes it a lot easier for it to capture what I really want. But the HPI was the area where I'm like, I think this is something that I want to know in terms of some stressor that my patient's having to deal with that the AI scribe did not think or deem nearly as important.
Varun, did that answer your question?
Yeah, it did. That was fantastic. Can I just ask one quick follow-up question? You mentioned and you provided a lot of focus on Spanish being one of the primary languages there. Has the scribe y'all are working with, has that been tested with Spanish? Is it the same process? What
Mhm.
does that look like for you?
So great question. So like probably a quarter of my patients are monolingual Spanish speakers, so I use it pretty regularly. Um, it's been hit or miss, to be perfectly honest. Um, there's certain things I'm like, no, that is not what the patient said and not what I said. So I'm having to go back in to fix certain things. Um, and I am concerned with Spanish being like such a prominent language in the United States, that if we have someone that's speaking Urdu or Farsi or Vietnamese, um, that we're going to run into even larger issues, because the platforms that they might be using a Google interpreter or Google Translate as their platform, which isn't like medically vetted as well. So that's a concern that we're trying to look into. But we currently, a number of our providers that are on it, Spanish is the dominant language that they also speak. So we haven't run into the issue with some of the other languages yet.
Great. The next question is from Amol. How do you deal with patients who, in the middle of a visit, say they don't want certain sensitive info in the note? Do you turn off the scribe, delete later, show them?
Great question. I haven't run into that too often, to be honest, but part of it is some of my patients are OGs. I've had them for like a decade, so they're pretty used to me. But that's a great question. I generally would just pause during that time frame and then restart it. The pause is very fast, so it's not something that I'm overly concerned about. And or I try to probe as to why. What's their concern about having it in the note? We can also just set the chart note to be sensitive, so you have to like break a glass to open that chart note, so it's something that people don't have regular access to.
Great. Then I have a question about ROI from Sophie. Have you tested your hypothesis for the ROI? For example, one additional patient to cover the monthly cost.
So we're actively looking at that right now. Um, that will help us for sure. Actually, our productivity did actually go up by a pretty significant margin. And since we have like 8 of us that are using it, I anecdotally that would make a lot of sense. But that's something that I do want to take a look at month over month for those that didn't previously use ambient assist versus those that did. I can definitely tell for our newer providers, it's been a huge benefit because they tend to see a lot more new patients that take up a lot of time. So in those situations, they're not having to go back and spend another 15 to 30 minutes documenting everything that's happening in the visit. So for them, I could think of definitely one of our providers. It's been huge. But the other thing is, for our organization, we try to enforce submitting your charges within 72 hours. That was something that this particular provider ran into a lot of challenges with, but now that's not been an issue. So we're able to get our reimbursements a lot faster.
Right. We have time for about maybe one or two more questions here. I see some overlap with Carolyn and Jackie around HIPAA. So maybe more specifically, I think you talked about HIPAA a little bit, but are the apps that you're using HIPAA compliant? And is there any risk of a staff use device getting hacked and inadvertently releasing patient information?
Excellent question. So yes, they're HIPAA compliant. Um, that's part of the reason why we wanted to make sure that it was something that was built into our EHR. So NextGen Mobile is something that we were already using. The NextGen Ambient Assist was just an overlay. So it was a HIPAA compliant platform for us. In terms of if folks were to try to put NextGen Mobile onto their own personal devices, you had to have like two-factor authentication to get into it. So you had to use like your finger or put in a separate password from the password for your phone into the platform. So that was something that we did consider. But most of the folks actually have been using one of our devices to use the platform.
Great. There are lots of questions in the chat, Dr. Hakeem, and we'll put a pin on all of those questions because they started coming up toward the end as they do. Really excited about all of your questions, everyone. I do want to move us into closing this session and kind of let everyone know what's coming up and how you can continue to be involved. Again, thank you so much for this presentation and answering all of the questions, Dr. Adenei. We will be following up with you to get some answers for folks in the follow-up email. So we can get some slides up real quick. I know folks are starting to hop off as you have your lunch hour ahead or your next meetings, but I just wanted to plug save the dates. Like today, we have our monthly AI in Action series. So next month on May 8th, we will have another monthly meeting, and we'll be providing more details about the speaker and the topic for that session. And there'll be some links in the chat to sign up. And then on April 30th, Health AI Partnership, CCI, and Alliance Chicago are putting on a webinar on navigating the AI landscape for the safety net. So we'll talk about our partnership, some resources and frameworks, and then we'll have a panel to talk about opportunities, challenges, and the path forward for the safety net. So we hope you will join us for our April 30th session and again in May. And then lastly, I think Nikita's going to drop a link in the chat for our, oh no, we're doing a Zoom poll. So maybe let's kick off that Zoom poll just to evaluate how this session went. This is our second one, and we want to make sure that we're improving it for the future. So if you can take a moment to fill out this poll before hopping off, that will be a gift to us. And then in addition to that, if you have any topics that you would like us to cover in a future session, please share that in the chat. We capture all of these notes. We take note of all of your questions and topics of interest, and that will help us plan for future meetings. Oh, I see Nikita's put a link in the chat, actually, a link in the chat for feedback. I'll drop it again here. So take the last 2 minutes for that. Otherwise, if you're hopping off, thank you so much for being with us today, and we hope we'll see you next month and on April 30th for our webinar.